Yeah. Okay.
Great. Good morning from Colorado, and looking forward to a session of very interesting papers. I'll ask each presenter to take about 10 minutes. And when you finish your presentation, please exit screen share so we can open up as a group for Q&A for a little bit. All right, so our first paper is by Julien Bergeot, looking at elder parent care. Julien, if you'll please share your screen and start your presentation. Julien, you need to unmute, please.
Oh, sorry.
There you go.
So thanks a lot for the introduction and inviting me to the workshop to present this research. I'm currently an assistant prof in Ca' Foscari in Venice, and today I will talk about care for elderly parents, and I will talk a lot about informal care, which is care provided for free or received for free, and generally by family members. So to give some context, you may all know that population is aging in most developed countries, and that to enable the growth, and that most countries want the older individuals to go old in their own home, because we also expect that having more people living in nursing homes would increase the public expenditures toward long-term care. And so we expect that the demand for care will increase in the community. What we should also know is that at home, the main source of care received by older individuals is the family. One example is France, my home country, where in 2015, 82% of the individuals were receiving informal care, so care received for free by family members, and 43% were receiving formal or professional care. And also, children play a significant role because among the unpaid caregivers, 52% of them were children. This is why I think it's important to understand the allocation of informal care provided to the elder individuals living in the community. And this is what I will study in this paper. Another element of context is that we know just a little about the decision process of the children. And it's very important because we know that the decision process will determine the level of care received by the parent, which will also impact the well-being of the parent and the role of the public policies. A second reason is that the literature includes several structural non-cooperative game theoretic models. So you have a literature in which people try to study the allocation of care between the children, and they use a non-cooperative model that I will present later on. Although this assumption is plausible in theory, its credibility could be improved with an empirical support. This leads me to two questions. So the first question is whether siblings cooperate or coordinate with each other when they decide to provide informal care to their parents, or do they decide upon caregiving, taking their siblings' involvement as given, which means that when a child decides to provide informal care or not, he maximizes his own utility, taking the behavior of the sibling as given. So the first one, when they coordinate together to decide to provide informal care, is when they cooperate, and the second one is the non-cooperative behavior. To study this question, I will develop a model in which children decide to provide informal care or not to their elderly parent. I will develop it in a cooperative and a non-cooperative model. I will estimate the model with data coming from France, in which I have information on the parent, so the health of the parent, the limitations of the parent, the help received. a list of up to 10 informal caregivers and also the children characteristics, such as where they live, their employment status, their age, gender. And then I will compare which model fits better the allocation we observe in the data. And another step that I will have, because it's not whether children cooperate or not, theoretically could have implication on the level the level of care the parent receive, but it doesn't say whether the parent does not receive enough care or not. So I will also try to study whether the lack of cooperation of the children result in more unmet needs for the parent. So just to have a brief review on the literature, there are very few papers trying to compare the fit of cooperative and non-cooperative model in the context of informal caregiving. So there is a Knuth and Kurman and Engers and Stern. And in the location choices, so in a model in which children decide whether to live close to their parent or not, there is a paper by Maruyama and Zhou. The main contribution of this paper with respect to this literature is to use a more flexible utility function. I also explore the determinants of cooperation. Although this was also done by Knuth and Kurman, I provide new evidence on this in the French context. And an important contribution of this paper is to study how the lack of cooperation can be detrimental for the parent, because this was not studied before. So these are the results I obtained in the paper. So first, as I told you, I estimate a cooperative model and a non-cooperative model, and I compare their fit with what we observe in the data. The first conclusion I have is that children seem to behave according to a non-cooperative model. So children seems to not coordinate when they decide upon caregiving, and this is the most predominant decision process, although I also show that there are families where children cooperate. And another implication is that the level of care is lower than if children would cooperate. One question we might have in mind is, okay, the children do not cooperate, provide less care than if they would cooperate. But does it mean that the parent does not receive enough informal care? Because if they receive less care, doesn't mean that they does not receive enough. To answer this question, I construct an indicator of the degree of non-cooperativeness. And in the data, I know all the activities of daily living and instrumental activities of daily living for which the parent has limitations. And I also know all the activities for which the parent does not receive any care. This allows me to construct an indicator of the number of unmet needs the parent has. And then what I do is that I study the correlation between the number of unmet needs the parent has and the degree of non-cooperation of the degree of this parent. And what I find is a strong and positive correlation between the unmet needs of the number of unmet needs of the parent and the degree of non-cooperativeness. This means that the parents having kids that are the less cooperative have more unmet needs. And these results can be interpreted as a sign that the lack of coordination is indeed detrimental for the parent. So to conclude, we may also want to have some policy conclusions from these results. So since parents receive less care than if children cooperate, and this is detrimental in terms of unmet needs, we would like to try to push children to cooperate, but this might be difficult in practice to find a policy that pushes children into a cooperative model. We could try then to incentivize children to provide care to increase the level of care received by the parent using, for example, caregiving allowances, taking into account informal caregiving into pension points. This was explored by Corfage in 2019. Also providing certain fiscal advantage for caregivers. But we should also be careful when we try to incentivize the provision of care by the children, because there is also a large literature showing some detrimental effect for the mental health of the children. And so there is a balance to find. Another way would be to increase the level of publicly funded formal care that can reduce the number of unmet needs for the parent. This was theoretically discussed by Conrad and Lumerud, and was also studied in the French, empirically studied in the case of the French long-term care system in France by Fontaine in 2012. But this policy recommendation is also hard for me to push from my paper because, as you saw, professional care is outside of the model that I use. So thank you very much for your attention.
Thank you so much. That was a great overview of the paper. If you can exit out of screen share, we will open up for Q&A. Would anyone like to offer a question or comment? So I was wondering if in your analysis, you only consider time investments in care, or if you also consider monetary investments.
So here there is only time investment. So in France, what I observe is that there is very few kids that are paying professional care to the parent. And so I decided not to include it in the model because this was less than 3% of the kids that I was observing. So this is out of the model, but I believe this is also a way to provide care and could be additive.
Almost.
Oh, I had this very similar question. Care is multidimensional. I wondered, how did you measure it to capture those dimensionalities?
Yes.
It can be finance, it can be transport, it can be time.
Yeah. So here the way it measured is declared by the parent, who is the interviewed individual. And what the parents say is the list, so they give a list of up to 10 informal caregivers. And they are also given a list of activities for which they can receive care, which will include a lot of activities of daily living or instrumental of activities of daily living, including transportations. And then they will give a total number of care they receive by these children on either daily basis, weekly basis, or monthly basis. And this is how I measure the time investment of the children. And in the model, I converted into a discrete choice, which is whether the child provides care or not.
Okay, thank you.
Thank you so much, Julien. So we'll move on to our next presentation. This is by Anna Rosso, whose presentation is going to be on domestic violence perception. Please go ahead and start, Anna.
Okay, can you see my screen?
Yes, I can see your screen.
Okay, thank you very much for this opportunity to present our paper. This is joint work with Veronica Grembi and Emilia Barili. So just starting with the motivation. So domestic violence is structurally underreported and yet at the same time is a widespread phenomenon. Only a minority of cases are in fact reported, and this is due to some very objective factors. The fact that the woman doesn't have, for example, the power to leave the violent couple, or some subjective factor, the fact that the woman believes that it's okay to be a victim, or some behaviors are somehow accepted. At the same time, and this is exactly what we study, perceptions matters, and perceiving a behavior as deviant, so the subjective factors that I was mentioning before, from what is acceptable in a relationship or a couple relationship in this specific case, is somehow the first step in dealing with that form of violence, both formally and informally. So, I mean, formally just reporting to services and to the police, for example, but informally even just reporting to friends, because that is also somehow a case that it's in many cases not even reporting to the network. Population perceptions play a role, and this is more like a general thing, in driving the legislation that supports the victim. And so seeing the issue more as a social problem and not only as a private matter. So therefore, it is important to really understand what drives domestic violence perceptions in terms of, it is important to define, in order to understand what drives perception, in order to understand what are the appropriate policy, it's really important to understand what drives these perceptions. And like, for example, higher awareness might bring to a lower incidence of the most severe cases by simply giving awareness to the victim and about the fact that that type of behavior is not correct. At the same time, also giving awareness to the abusers that that type of behavior is not correct, just as simple as that. So in this paper, we just try to just answer a very simple question, is what is the link between perception of domestic violence and gender stereotypes? We do this by, we create our own survey, so a unique survey of more than 4,000 women that are aged 20 to 65 in Italy. They're representative of the Italian population. We measure perception of domestic violence, so we do not measure, we do not use any formal measure of reporting, but we ask our respondents to report what they believe it's their perception about the diffusion of domestic violence, about the severity of cases, the causes that might somehow justify some behavior, and the hypothetical advice they would give to victims. And also important in our work is that we measure gender stereotypes at the individual levels. In most of previous literature, gender stereotypes were measured, and this is because of the surveys that provide this information. They were more likely to be measured at the aggregate level. We're able to link this individual level perception to individual level gender stereotypes. So that is an improvement with respect to the previous literature. We find that women with stronger stereotypes are more likely to systematically rank social and economic violence as more severe than physical and sexual violence. To some extent, physical and sexual violence is somehow more accepted for this type of women. They're more likely to justify domestic violence as resulting from temporary situations, like it's fine, it went through a very stressful period associated, for example, to an economic crisis, but less likely to link violent behaviors to long-term problems of the abuser, and therefore somehow giving a solutions that, or somehow supporting the abuser in this issue. They're less likely to recommend formally reporting the event or using even the available support. And I will show you some results of that. And in some cases, they also are more likely to say, do not talk to anyone about this. The empirical strategy is very simple. So these perceptions that we measure can be determined by personal experience. There's like a large literature, especially sociological literature, that shows that violence can be intergenerationally transmitted. So we try to measure this personal experience in our survey. It can be a function of the gender stereotype, which is our focus of the paper, but also of individual level characteristics that we try to measure in our survey, but also neighborhood characteristics. So the context in which the person lives, that is somehow that's helped by regional fixed effect, but we also provide some extra measure of the neighborhood in which the individual lives, what we call the context, sorry. So just to give you an idea of how we measure the perception of domestic violence, so the first measure we use is the diffusion. We ask individuals how they feel that violence is widespread in their community. We define, so we ask them to focus on either physical violence or psychological violence. And just to give you an example, so 9% of individuals in our sample say that physical violence is highly spread, whereas 22% think that psychological violence is highly spread. And then we look at severity. We ask individuals to rank some behavior that we aggregate into economic, social, psychological, physical, and sexual violent behaviors. And as expected, individuals on average, they tend to rank economic violence as less severe than sexual violence. But as you can see from the first panel, panel A, there is a lot of variation, which means that it's not always the case that economic violence is ranked lower than sexual violence. Okay, and this is seen as, once we aggregate the data at the provincial level, all this variation disappears. That's why it's important to try to measure this perception at the individual level. Then we also ask about the justification they would give to a violent behavior, like the fact that the individual, there was COVID, the fact that the individual went through some very important crisis like economic crisis, or simply it has some issues like psychological issues, so that's why that sort of behavior can be justified. And then finally, we also ask individuals what they would advise a victim to do, whether it would be reporting to the police, and 52% of the individuals say that it's something they would advise them to do. But there's also like a 5% of individuals of women that say, do not react, do not do anything, just ignore that. And then finally, 30% of our respondents claim that they should just talk to the partner and try to solve the issue within the household. So again, personal matter versus social matter. Just some of the results from the empiricals, from just running the empirical strategy that I showed you before, where on the left-hand side we have all those outcomes. When it comes to diffusion, it seems the stereotypes are actually not linked to any measure of their perception of the physical diffusion of violence, but so women with higher stereotypes are less likely to believe that psychological violence is highly diffused. When it comes, and this is very interesting, when it comes to the severity, so how they feel that, how severe that type of behavior is, women with higher stereotypes are less likely to rank sexual and physical violence as high, but more likely to rank social and economic violence as higher than, more severe than the other type of violence. They're more women with higher stereotypes. They're more likely to justify the behavior, has some sort of trend, justified by some economic crisis or something that is not due to the type of individual that is the abuser. And then finally, when it comes to reporting, women with higher stereotypes are more likely to to advise victims not to report. Okay, and this is to give you an overview of the results. So domestic violence reporting is strongly linked to the individual perception of the prevalence and severity of the gender violence, and underreporting is somehow linked to this systematic underestimation of how severe they believe that this domestic violence is. And it is believed that it's rare. And this is surprising because 30% of the population, of the women population, claims to have been a victim at least once in their life of some sort of gender-based violence. And in most cases, it's actually the reason why it's because there is a large underreporting and because this issue is perceived as a private issue. So somehow changing the perception of domestic violence can affect the public opinion and make women more empowered to deal with that. And so we try to focus on this role of individual alignments with gender stereotypes in defining this perception. And we do see that gender stereotypes, they do. So the roles that women have in their society, they seems to matter a lot in how women perceive domestic violence. And yes. That's it. Thank you very much.
Thank you very much, Anna. You can exit out of your screen share.
Yes. Thanks.
All right. And since we're a small group, please, if anyone has a question or comment, please just unmute and speak up. You don't need to raise your hand. So, Anna, I was wondering if you investigated any mediators or interaction effects. Is there anything that, whether there's anything that, besides changing the gender stereotype perceptions themselves, might reduce the underreporting or different perception of domestic violence?
No, we in that specific survey we have done several checks to really try to understand and pin down what the effect would be like. For example, the media could play a role in over and above what gender stereotypes has, and we see that the role of gender stereotypes somehow remain, even if like individual during COVID, because we ran this survey during COVID, were more exposed to television, for example, so they were more likely to have a different perception or to be like to stay in the same household as their abusers, so therefore maybe mature different perceptions of their situations. But we do not see any change in so net of this effect, we do not see any so the gender stereotype is still play a role. What we are running at the moment is some sort of informational survey to see whether information can play a role in changing the perceptions that women have on domestic violence, in terms of making it more of a public issue and less of a private issue. But that was somehow that was the beginning of like a research agenda that will try to deal with some of the mediators you might be referring to.
Thank you so much. Okay, so now we are ready for our next presentation. This will be by Riccardo Ciacci, looking at the consequences of the Swedish case of banning sex trade. So Riccardo, if you will just share your screen and begin your presentation.
Okay. Hi, everyone. Thank you for being here. You can hear me, right? So,
yes, very well.
I'm going to present this paper about the Nordic model and cases of rape. So basically, the two research questions I'd like to answer in this paper are whether criminalizing the purchase of prostitution has an effect on sex crimes, and if yes, what mechanisms can lead to this effect. We had different papers earlier in the literature studying the effect of decriminalizing sex crimes and their effect, decriminalizing prostitution and their effect on sex crimes. And this one, to the best of my knowledge, is one of the first looking at the effect of the opposite regulation. So criminalizing prostitution, in this case, is criminalization of the purchase of prostitution, so going through customers. So just as a preview of the results, sorry, if you see here, I am here with my dog, and sorry, she sometimes is also appearing. This is one of the first papers to study the effect of the criminalization of the purchase of prostitution and rape. The effect found is that this regime increases sex crimes. And the results are robust to multiple specifications, which how we are going to see, since the difficult setting are needed to have a more credible approach. And then in the scholarship, it was discussed earlier that criminalizing could have an effect that in absolute value is larger than decriminalizing, and this is what is found. Moreover, the mechanism analysis highlight that this result might be demand-driven, which is not a surprise since the criminalization is affecting the demand. So first thing to summarize this paper in 10 minutes is just to give introduction about the law. The law that was effective since the 1st of January in 1999 in Sweden prohibits to buy sexual services, but not to sell them. This is quite explicit in the law. And customers face a risk of either a fine or even prison, depending on services, the prostitution, the sexual services they buy. So in order to answer this question empirically, the first thing I do is to build a regional monthly panel database for Sweden, which comprises 21 regions from January 1998, which is the first month for which we have data available, to December 2014, which was when I started studying this topic and for which the data was available at last. So this data comes from the Swedish National Council for Crime Prevention. And then I also use data to proxy sex tourism from the Swedish Transport Agency. Moreover, I use data on the number of officers hired per region each year. These data are available from the Swedish Police Department. And so the first picture I'd like to show you is before and after event comparison, monthly data, with rapes in logs averaged by quarters. And so we see that there is a jump there. And so the second question we have is whether how much of this increase is taking place in January, just because it is taking place in January, which would be sort of a naive OLS. And so this would be a 125% increase. And so then the question is, how much of this is due to the policy and how much is due to something else? I use different econometric techniques. And the first econometric technique I use is a regression discontinuity in time, where I have the whole sample, so from January 1998 to December 2014. And I have in the first column results in logs, and in the second column results in the inverse hyperbolic sign transformation. And I use first order and second order polynomial. And we see that roughly between 50 and 70% of this increase could be ascribed to this change, depending on the functional form. Then I restrict the sample only to 2 years before the policy, sorry, 1 year before the policy went into effect and 1 year after. And this effect decreases a bit between 30 and 40%. Then I carry out different specifications, because one might expect that, might doubt that this effect is due simply to January. Maybe people could think that in January, because of things that are happening in January, like I don't know, New Year's Eve or winter taking place, and even if we have taking into account months fixed effect, well, maybe this could be an issue. And so I take a difference in discontinuity approach, and results are robust to that. I do the same for a restricted sample. And then I use different econometric techniques. I have fuzzy difference in differences following Chance-Martin and Doltofel. So also in this case, in this case, actually, we use data on fines. And also in this case, we find that there is an increase on sex crimes due to prohibition of the purchase of sexual services. With an even study analysis, results are similar, and we find that the effect, moreover, stems from the same months in which the fines take place. And then I do also an IB using data for sex tourism as an instrument, using data actually of flight offerings, assuming that when there are more intercontinental flights, since it's an issue actually in the parliament in Sweden, it was debated to criminalize also buying prostitution elsewhere, so in other countries. So using these flight offerings, again, instrument fines, and also in this case, we find an increment. If we compare these estimates, so the last three, fuzzy difference indifference, which is bold DID coefficient, the IV, and the even study, which is the gray line, we see the three are similar, while the less is much lower. And then if we estimate the effect of the policy, because the last three, so the fuzzy different diff, the even study, and the IV, use fines, and so we need to compute the effect of the policy using the total number of fines, we see the policy has a similar effect. And actually, some estimates are more precise than others, also depending on the number of observations they use. As we know, the regression discontinuity and the difference discontinuity one expected, especially the one that use the restricted sample, use, as they say, a restricted sample, so a lower number of observations. So the main results of the paper are that this ban increases rape between 44 and 62% from 1999 to 2014. The effect is temporary, as is highlighted in the even study, and takes place right after the fine is issued, so in the same month. If we compare this to the famous effect of Cunningham and Shah 2017, where they find that decriminalizing prostitution reduces rape by 30%, and then they have a paper, a review of the literature, where they say that the effect of criminalizing should be in absolute value larger. This is actually what is taking place. And this is also true if we compare it to the paper of Bishop and other, 2017, where they study the effect of street prostitution zones in the Netherlands, and where they find that these zones decreases rape. And so, as discussed in previous literature, the effects of criminalizing seem to be larger in absolute value than those of decriminalizing. And this is all for the 10-minute presentation. I guess now there might be some questions.
Thank you, Riccardo. If you could stop your screen share, and then I can open it up. Klaus, looks like you have a question.
Yes. Now, the issue I have is with the exogenality of the policy issue of how, I mean, typically, well, Sweden is considered to be the prejudice. It's a very liberal country. Why have they suddenly changed policy, become criminalizing prostitution? Is this an issue, or how you handle it? I have, of course, seen your before and after trends. Maybe so you have an argument against me, so to speak.
So I have a check in the paper about that, which is since the law was passed in June, maybe the effect could be anticipated. And if we run the same regression discontinuity for June, we don't find any effect. Moreover, only the two first approaches, the regression discontinuity and the difference in regression discontinuity in time and the difference in discontinuity, rely on this source of exogenality. The other one relies on a source of exogenality that stems from fines, and the IV that stems from sex tourism. And this is exactly why, exactly for this concern, which I share with you, I relied on 5 econometric techniques, which I think is not something common. But since I think the research question is really important, and somehow when we don't have good data in economics, sometimes we don't study these questions. So I think maybe with an extra effort, having more econometric techniques, we could try to answer also this question relying on different exogenous variation. I hope I answered your question.
Yes, thank you.
You're welcome.
Other questions or comments? Riccardo, just to clarify, it sounds like once you move beyond the base, the most straightforward RD, are you comparing areas of Sweden that had higher sex tourism in the pre-period to those without? Is that how you're getting your differences analysis? Is that the comparison, or is there a different comparison being done?
In the IV, I use areas where there are more intercontinental flight offer. And so in those areas, since in the parliament in Sweden, it was debated that many prostitution customers now travel to other countries where prostitution is legal, I could proxy the access to this type of tourism, which is called sex tourism. This is for the IV approach. While in the regression discontinuity in time and in the difference in discontinuity, I merely use the time difference stemming from the fact that on the 1st of January this law was active, was enforced, and before it wasn't, and that it was the first country to do so. So it was also unclear how this would affect, and so it was not. I guess for other countries, then Norway passed a similar law. I guess if we could have data for Norway, which I couldn't, I would need some funds to, because I contacted the statistical institute in Norway, but they asked for money, and so it's a bit more complicated for me to get this data. I guess in this country, maybe there could be anticipated effect, because after Sweden passed this law, then it was clear how to enforce the law. But before, there were some questions, actually many questions about it. Sweden was the first country to enforce it.
Thank you so much. Any other questions?
Yes, Tara, I would like to ask a question for Riccardo.
Sure.
My question is quite simple. Intuitively, is rape a much severe crime in Sweden than purchase sex service?
Yes.
So my question is rape much severe crime than purchase sex service in Sweden? So if so, why would people, to conduct like a heavy crime rather than just purchase sex service and take the fine if they get caught?
Okay,
that's my question.
Yeah, sure. This is a question I think related to microeconomics. Now it's sort of a substitution effect. So it depends. So now the prices of these two are changing. For some people, maybe depending on also how likely they consider to be caught committing rape. Rape actually suffers a lot of underreport. So maybe some people could think, you know what? Now since now prostitution is more severely punished, I will try this. I don't know if this is like sort of economics of crime. If we read the Gary Baker, the first paper, now it's less likely that I will be caught committing this other crime, because now this one is much more likely I'll be caught, because now this is considered a crime to purchase prostitution. So I would simply see it as a substitution effect, but understand the question that for the mass majority of people, if they believe that rape is much more likely for them to be caught, simply for a rational expectations analysis, they will say, okay, I prefer to do another thing, to buy prostitution in this case.
Okay.
So it's a difference in the relative price, I see, and in the probability of being caught also playing here a role.
Thank you so much. Wonderful discussion. All right, so we'll move to our next paper by Zongzhi Liu, talking about the effect of North Korean nuclear tests on the Chinese border. You can start your presentation. Thank you.
Okay. Hello, everyone. My name is Liu Zongzhi, a PhD student from Nanyang University, and the article I'm presenting today is the threat beyond the border. King Jong-un's nuclear test and the China's rural migration, which was collaborative completed by myself, Zhou, and Tian. Since 1948, nuclear activity has posed threat to the humanities primarily through two avenues: reactor accident and the nuclear weapon test. There have been 13 major nuclear accidents to date. However, over 2,000 nuclear weapon tests have been conducted worldwide. Research on the nuclear accident have addressed the adverse impact on healthy mental being, nuclear anxiety, migration, and property values. However, the research on the effect of the nuclear weapons test is limited. Since 2006, North Korea has conducted 6 nuclear tests, with the test site located less than 80 kilometers from Chinese borders. Each test triggered the earthquakes in the border regions, leading to the evacuation of the school children and the residents. In summary, the nuclear test posed a potential nuclear risk to the residents in border areas of China. So we utilize the nuclear test as a natural experiment to investigate their impact on households near the shared borders. Our findings reveal that the nuclear test elevated the risk of the human-made radiation and increasing the level of migration in China's border regions. Additionally, nuclear tests also diminish the viability of the village, leading to household out-migration. Furthermore, households with a higher human capital, higher income, and fewer elderly household members are more pronounced in out-migration due to the nuclear test. Our contribution entails of the perennial investigation of nuclear tests near the Chinese border regions. We treating them as an environmental risk event. We concentrate on the impact of the human-made nuclear risks on household migration, diverging from the conventional focus on the nuclear accident aftermath. Moreover, we underscore the rural coping strategy whereas the urban west, highlighting the rural vulnerability to nuclear leakage due to the reliance on the natural environment. So, as the nuclear test persists, the Chinese government have intensified the monitoring efforts to detect and prevent the nuclear leakage. Following the 2006, China began emergency radiation monitoring. After 2009, China boosted the monitoring with extra vehicles and lamps. Post-2013, continuous monitoring along the North Korean borders was established. Border area residents near the North Korea expressed concern about the potential nuclear leakage. According to the Battle Index, similar like the Google Trends, border residents in border cities are 3 times more worried about the nuclear test compared to those in non-border cities. A service in border areas found that higher education and the income linked to the increased concern over the health effect from the nuclear test. We argue that working outside the home county and leasing farmland are key migration metrics for households. Due to the strict control on formal migration, rural households often engaging in temporary labor migration in China, and the complete farmland list out implies reliance on the off-farm labor opportunities. And as shown in the figure, following the nuclear test, border region households experience a much greater increase in migrant days, and the proportion of the border areas households leasing out land completely increased significantly, surpassing the non-border area household. The subsequent test widened the gap between the border and the non-border regions. So our study used NFPS annual wave sampled between 2003 and between 2003 and 2017, offering advantages such as spanning pre and post-nuclear test period since 2006. The service areas included Jiang, Jilin, and Liaoning province bordering North Korea. So we using different frameworks. Our studies compared 2 groups. The treat groups comparing rural household in 7 border villages with North Korea, and the control group consisting of the rural household in other Chinese cities without North Korean borders. The distribution of the sample value is depicted in the company figures. The following regression equation is employed. The y underscore HRT are our main explanatory variable household migrant days and the complete land list out. Border is a dummy variable indicator valid from the border regions. Post is a dummy variable indicating 2006 and later. And we also control the vector of the household, the vectors of household and valid control variables. And we also household fixed effect and the year fixed in our model. When potential concern is the fluctuation of the household's composition over the sample period, caused by both the new additions and the attrition from the service. To address this, we narrow our analysis to the household present both before and after 2006, forming both side samples. Furthermore, we also refine the sample to include only household present throughout the entire sample period, creating a balanced sample. Our main results show that after the nuclear test, border area households significantly increased their migrant days and were more likely to fully list out their land. Moreover, the conclusions remain consistent whether we analyzing the result from the both side or balanced samples. We conduct a direct test comparing the trends between the treated and the control groups before the test. Results show no significant difference in the trend before the test, satisfying parallel trend assumption. To validate our findings, we explore alternative treatment and control groups. In the first scenario, the treatment group consists of the rural household in the North Korea bordering regions, while the control group comprise of the rural household in non-border areas of Jilin and Liaoning province. This helps us to ensure the comparability in the regional characteristic. The robustness results are in line with the baseline result when focusing on the Jilin and Liaoning province. Considering the nature and the social variation between the border and the non-border regions, we conducted robustness tests by modifying the control group. In this scenario, the treatment group are still border village near the North Korea, but while the control group are village bordering other countries. This result also confirms the baseline findings. This section investigates economic changes in village following the nuclear test. Regression results show a decline in economic activity in Chinese village along the North Korean borders. Especially, nuclear tests lead to a significant decrease in agricultural firms, cooperatives, and scale families. Additionally, collective investment declined significantly. We investigate if the nuclear test promotes changes in household behavior by affecting the village level economic dynamics and subsequently influence their behavior. In summary, the regression results say that the economic variability of the village serve as an important buffer to prevent the rural household from moving away from their village. And these buffers were also, and these buffers are also weakened after the nuclear test, further causing the rural household to migrate away from the rural areas.
So Zhongzhi, one more minute, please.
Okay. This section found that the nuclear radiation is significantly increase the migrant days and the likelihood to complete land leased out. This effect is more pronounced for households with higher human capitals and higher income and fewer elderly members. In this end, the nuclear radiation risk causes the rural household with the means to migrate away from the border rural areas to do so to the greatest extent possible. Here is our conclusion and discussion. Following the nuclear test, households respond to the nuclear radiation risk by increasing their ability to migrate from the rural and agricultural activities, and seeing increased migraine days and the likelihood of the complete land lease out. Economic viability of the village crucial for retaining the farm households. Diminished post testing evidence in decreased rural farms, cooperatives, and the value investment contributing to out-migration, and household with higher human capital, higher income, and a younger composition are more inclined to move away from the agricultural and rural areas due to the nuclear test. Actually, the rural holding out in China border region. Thank you for your attention.
Thank you very much. Questions or comments? Almost.
Thank you. I have two small questions. One is how one can separate in a good way economic versus nuclear test migration, because those two might be like part of the migration be economic, not necessarily nuclear test related. The second one is how can we separate migration from the normal urbanization that in China has been very rapid since the open door policy. Thank you. Did you understand the questions, or you want me to repeat them?
Yeah, maybe
It was
maybe start with just
two-part.
one. Maybe just one instead of two questions.
Okay. How can we separate economic migration from nuclear test related migration? Because those two will be very difficult. And in China, a lot of people have migrated, urbanized because of economic reason.
How can
separate migration because of for economic reason versus migration because of nuclear test related?
Separate migration whether
Yes,
is caused by the nuclear test or by the
Yes,
economics
yes.
of the economic
Yes.
reason. In fact, we have ended some control variable for example the trade values between the Chinese cities and the North Korea, and the economics and economics and the GDP per capita. So we also found that the trade value and the trade value and the trade value or the trade value and the GDP in the border cities are not significantly changed after nuclear test. So yeah.
Thank you. Thank you.
Thank you.
Thank you.
Thank you so much. Okay, Klaus.
Yeah, you must see, I mean, migration is one effect, yes, which could have been correlated with the nuclear test, but something more closer, more easier to look at, perhaps, or not, if you have the data, is what happens to fertility or to well-being. If you have measures of well-being, you should see directly something. Migration is something more heavy and interactive with other issues. Do you have such data, or it could be as a robustness check, yes, or a further paper? Well-being, measures of well-being. I mean, if there, or fertility, well, you're risking the health of your kids.
Right. Yes, Klaus. Let me try to answer the question.
So I'm gonna suggest, because of time, that we move on to the next thing, and perhaps you can follow up with the author by email for the later questions, if you don't mind.
Sure.
Okay.
Yeah. Thank you.
All right. Thank you so. Thank you, Zhongzhi. We're going to move to our next presentation. So Valentina Paredes is going to present on maternity leave and infant health. Valentina, if you can.
Thank you, Tara. This is joint work with Fabian Duarte, Cristobal, Bennett, and Isabel Poblete. There. Okay, so although 170 countries have some form of maternity leave, there's still discussion on this policy, where defendants of the policy argue that it contributes to the health and well-being of mothers and children. So it's important to quantify these possible positive health returns from such policies, especially given that the literature has mixed results, with papers for Canada, Sweden, Austria, and Denmark finding no results, and some papers for California and the US finding very strong positive results on health. So in this paper, we examine the effect of extending maternity leave on infant health, and to do so, we exploit a Chilean maternity leave reform that increased the number of paid leave from 12 to 24 weeks. We use administrative data for women enrolled in the private health insurance system. This covers around 15% of women in Chile. And we measure infant health as the number of paid sick leave days taken by the mother due to their infant being sick during the first year of life. And we also explore the effect of this reform on pediatrician visits. So let me tell you a little bit about the policy and the reform. So prior to the reform, maternity leave in Chile consisted of 6 weeks of prenatal leave and 12 weeks of postnatal leave starting from the day of birth. Both leaves include full income replacement for almost all women. There's a very small percent of women who don't have full income replacement because there's a cap. The most important thing here is that postnatal leave cannot be waived or so it is mandatory. Women have to take the maternity leave and cannot decide to go back to work early. So in October 2011, the legislation introduced a new parental leave that is extended the postnatal leave period from 12 to 24 weeks for most women, without changing the prenatal leave and without changing the other features. So we still have full income replacement, and we still have that these 24 weeks are mandatory. Also, because how the policy was implemented, all mothers of children younger than 24 weeks at the time of the implementation could benefit by the extension. So this is a graph where we have the date of birth. So here the reform was announced and enacted on October 2011. So from that day on, all births were fully covered by this reform. And also children who were born earlier than July 2011. So here there could be a child that is 20 weeks old at the time of the implementation. That child will have, the mother of that child will have 4 additional weeks of sick leave. So there was no discontinuity in the number of sick leave, maternity leave days. So this will allow us to study the reform using a standard linear model. So our proxy of health is the number of basic leaves. So in Chile, parents of children under 12 months old may request paid sick leave due to their child illness, but only for parents of children younger than 1 year old. Also, because some women are on maternity leave until their child is 6 months old, we only measure health with this proxy for infants between 6 and 12 months old. So all mothers have finished their maternity leave, and their child is eligible for requesting pay leave due to child leave. So we will use administrative data for all women enrolled in the private insurance system between 2011 and 2013. So these are children who were born between January 2011 and December 2013. We use a standard linear model where our a variable of interest is the number of legal leave. So it ranges from 84 to 168. So between 12 and 24 weeks. Our controls are log income and age, a general health indicator to control for seasonality of diseases, and month and year of birth fixed effects. So our results show that for the accumulated period, so for infants between 6 and 12 months, the extension resulted on a decrease of the 6 days taken by the mother. This coefficient should be multiplied by the extension. So women fully treated have 84 additional days. So this accounts for a reduction in a bit more than 6 days. Women on the control group have 20 days. So this is a 32% change. We also investigate this using separating the sick days by diagnosis. So we find that most of the effect can be attributed to diseases of the digestive system. This is the K diagnosis, and the respiratory system. This is the J diagnosis. There's some effect here on conditions originating in the perinatal period, but in the paper we show that this significant coefficient is not robust to all our robustness checks. We also explore the effect on pediatrician visits. We find that, especially here, mothers that are benefit from the extension can take their child to the pediatrician because they're on maternity leave, but we see a reduction of visits to the pediatrician. So this also supports the hypothesis that these children are more healthy than children not affected by the extension. Finally, in the paper, we explore some possible mechanisms. So there are many mechanisms through which the extension could affect infant health. In particular, it could promote breastfeeding, but using survey data, we find no significant impacts of the extension on the probability or duration of breastfeeding. Our results could also be explained by a reduction of group care. So these mothers, since they're on maternity leave, don't need to take their children to daycare, and that could decrease the exposure to some respiratory diseases. And we do find evidence using our survey data that there's a negative, a significant effect on the probability of attending daycare for infants younger than 6 months old. So as a summary of our results, we studied the effect of an extension of the legally required maternity leave in Chile. Our study shows strong evidence that the extended maternity leave decreased the probability of mothers taking sick leave due to their infants being ill. And we find that this effect also lasts after the even 6 months after the end of the extended maternity leave, indicating that there is a medium-term health effect. And our results are consistent with a decrease in daycare attendance, which decreases the exposure to communicable diseases. Thank you very much.
Thank you. It's very much. Let's open it up for questions and comments. Amos, please.
Thank you. I have a small question. You have quite a large sample, 54,000, which makes this debated coefficients very highly significant. But at the same time, the fitness of the model, fit of the model, R-squared in almost all models is less than 1. So what is the value of having such a low fit? And also, what did you miss in specifying the model to improve the fit of the model? Thank you.
Sorry, I have a very small, what?
Okay, you have a large sample, but R-squared is less than 1 in almost all models. It has to do with partially the specification. What information was most needed that you missed to include in the specification to improve the fit of the model? Thank you.
Yes, we have a large sample because we use administrative data. That's one of the advantages of our paper, but because we have administrative data, we also have poor information on the household. So our only controls are maternal age and income, but we're missing everything else. So other siblings, characteristics of the household, etc. Just a small thing that our result is also robust to smaller samples. So we also use smaller windows around the reform to check the robustness of our specifications, and the results are robust, but still the R-square is small and still the sample is large, even in these smaller samples.
Thank you.
One other question, Valentina.
Tara, you seem
to have sorry, my video. Sorry. One other question, Valentina. So do you find any differences in daycare usage in the 6-month to 12-month period?
No, we don't. We only find difference for children younger than 6 months. So that's when this, especially when they're between 3 and 6 months. So this is where the extension is having the effect. One puzzle that is left with this is that we find effects on health after 6 months when there's no difference in daycare usage. So that could mean that there's some maybe longer terms of on health of exposure at a small age. But to really disentangle the mechanisms, we would need to have better data.
Thank you so much. So I am looking and I do not see Evelyn Skoy, our next person on the program, on the call right now. And so I do see the presenter after that, Pietro. Klaus, if it's okay with you, I'll move to Pietro unless you have another, right? Sounds good.
Yeah.
All right. Wonderful. Thank you, Pietro, for being willing to.
Okay.
So we'll do Pietro Pizzuto, looking at pandemic crises and fertility.
Okay, thanks very much. Let me share the screen and then, okay, can you see my screen?
Yes, we can.
Okay, thanks very much for having me here and inviting us to this workshop. So the paper I'm going to present today is a joint work with Davide Furceri and Khatereh and Pietro Pizzuto from the University of Palermo. And this paper is about the effects of pandemic crisis on fertility. Basically, we know that we know all that COVID-19 pandemic have been a tough pandemic that the scars of the pandemic have been sizable in terms of inequality, livelihoods, reduction in income, and increasing in poverty. However, if we can somewhat look at the short-term effect of COVID-19, we may ask if these effects may persist over time, and in particular, what is the additional scares that pandemic may impose to the people in terms of childbearing intention and fertility. These are the main motivation of our papers, and in particular, the research questions that motivated this paper were the following. What are the short and medium-term effects of pandemic on fertility? The idea is to understand what are also the transmissions, the channels. Basically, we investigate two aspects that are how the pandemics relate to fertility through weakening in economic activity and also in increasing uncertainty. So what are the effects of these two transmission channels? And moreover, we investigate other heterogeneous, if there are other heterogeneities in the effects of pandemic crisis on fertility, depending on the age groups, economic development of countries affected, policy responses, and so on. In this paper, we start by looking at what happened in the short term, that is, what happened at least in the earlier stages of the COVID-19 pandemics. And we used a stringency index by Oxford to compute a preliminary, let's say, estimation on the effect of the pandemic on, first of all, on the fertility rates. So we regressed the fertility rates against 9 months lag of these stringency measures. And we find that indeed, at least at the preliminary, at least from this preliminary evidence, pandemics generate a negative effects on the fertility rates. That is, in our cases, of about 7%. In addition, we look at, let's say, these two channels that I mentioned, that is economic activity and uncertainty. And indeed, it seems that, again, from this preliminary evidence, pandemics, of course, and we all know this, weakened the economic activity, having a negative effects on GDP, but at the same time, pandemic, so the COVID-19 pandemic increased also the uncertainty that in our case is measured by the World Uncertainty Index. It is a proxy of economic and policy uncertainty. But this is the short term. A key issue is, in our view, is whether these effects may, let's say, be persistent. So if this weakening of childbearing intentions due to the pandemic may persist over time, since we know that in the past have happened, of course, other pandemics or other major epidemics. We looked at this to try to, let's say, project in the future what can happen in future years, in the coming years after the COVID-19 pandemic. In particular, we looked at the pandemics of the latest 20 years, starting from 2000, that are namely SARS, H1N1, MERS, Zika, and Ebola. And we use a methodology very well known especially in the macroeconomics, that is the local projection approach. So we estimate the medium-term impact of a pandemic crisis on fertility rates through this approach, that basically it consists of regressing for several periods ahead the estimation, the equation that is shown in this slide, to understand and to trace the impulse response function of fertility rates to pandemic crisis. Then we also augment this baseline dynamic linear model to account for heterogeneities, both in terms of transmission channels, as I mentioned before, but also looking at other characteristics. The main results or the baseline results that we found is that post-pandemic of previous, let's say, 20 years before COVID-19 have had a negative, statistically significant effects on fertility rates that is persistent, persistent over time, in the sense that in the medium term we can observe this effect that peak at a time equal to 5 in our case, that is 5 years after the pandemics, at -2%. Interestingly, these effects are heterogeneous by age groups, with the youngest women that are the more affected, where the effect on oldest women is less evident and mostly not statistically significant. And also the effect is heterogeneous across income groups. So the effects are larger for advanced economies with respect to non-advanced economies. These are the key baseline effects. Then, of course, these results are robust to several checks that the results are not shown here to save time, of course, but are available in the paper. These just to summarize, we excluded the one pandemic at a time. We used alternative measure of, let's call it in a broader sense, fertility, total fertility, birth rates, and other dependent variables. We used an alternative database like the UN data, while the baseline analysis are done with the WDI data on fertility. We added the controls. We checked for endogeneity issues using GMM and IV approaches. Everything is available, of course, in the paper. But now let me focus on the transmission channels. As I mentioned, we think that these effects may depend. I mean, the baseline effects may mask some heterogeneities, and especially depending on the strength of the transmission channels. As I mentioned, we think that the most important transmission channels are two. One based on the economic activity, and the second based on the uncertainty generated by the pandemics. And using the data of past pandemics, we find the following results that basically confirm our hypothesis. And indeed, even past pandemics had a negative effect on economic activity, that is reducing GDP growth and having a negative effect on employment rate. Why, at least in the short term, they increased the uncertainty, the global uncertainty, so the economic and policy uncertainty. So our additional hypothesis is that the effect of pandemic crisis on fertility may be asymmetric, may be heterogeneous, and depend on these characteristics. And this is the case. Indeed, we find that the effect or the negative effects of pandemic crisis on fertility rates is larger in the countries that experienced a lower GDP growth, a lower employment rate, and a larger increase in the uncertainty at the time of the pandemic. Not that this is, of course, these are the average results, but when we do one step ahead, that is discriminate between advanced and non-advanced economies, what we find is that even if these channels seems to work on average in both advanced economies and non-advanced economies, there is a larger importance of the channel related to the employment rate in advanced economies with respect to the non-advanced economies, where the predominant channel is that one related to GDP growth. And basically, this depends on the larger effects of pandemic crisis on employment in advanced economies with respect to non-advanced economies, where the larger effect is identified. I mean, observed. Sorry, is observed for GDP growth. One more thing is that that differentiate. I mean, why pandemics are relevant, since they are particular in nature, in the sense that have a specific effect on the economy and, of course, on the childbearing intention and on the fertility rates as a consequence. And in particular, they have a specific importance since they are different from other kind of recession, like a simple recession that we can identify using negative growth rates of the GDP. And this is true especially for fertility rates, since our estimates suggest that pandemic recessions have a larger effect on fertility rates with respect to, let's call it, traditional recession. And in our view, this happens mainly through the larger effects that pandemic recessions have on the employment. Indeed, on the right-hand chart, you can see a comparison on the effect of pandemic recession on total employment. And as you can see, this is larger for pandemic recession with respect to, let's say, only recession.
And so, Pietro, one more minute, please.
Yeah, I'm finishing. Last slide. In such a challenging scenario, there is we asked if there is a role for policymakers, and in our view, there is a role, a key role, a crucial role, I would say, for policymakers, since we noticed that when policymakers react, especially we investigated the fiscal policy channel. So when policymakers act using especially fiscal policies to augment health expenditure, the effect of negative effect of pandemics on fertility rates may be offset and maybe reduced at least, since we found that when the government health expenditures at the time of the pandemic were high, the pandemic recession had not statistically significant effects on the fertility rates. So our key findings are basically the following. We find a negative effects of pandemic recession on fertility rates. The effects are heterogeneous and depend on the age of the women, the income of the level of development of the countries. It depends on several transmission channels where the economic activity and the uncertainty generated by the pandemic are the most important, but also other characteristics like the role of policy are relevant, especially related to fiscal policy applied to the health sector. Thanks very much.
Thank you, Pietro. If you can exit out of your screen share.
Yeah.
All right. Thank you very much. I'll open it up for questions or comments. Yes, Almas.
Sorry, I didn't want to be the first every time to ask question. But my question is, you mentioned about fertility, you mentioned about income, you mentioned about unemployment. I think one has to deal with issue in form of simultaneity and interdependence, that pandemic affects employment, income, and income uncertainty, and has a feedback to fertility or whatever you look for. You mentioned about endogeneity, but that is not exactly simultaneity and interdependence to estimate all those simultaneously together.
Okay, no, I think that thanks for of course, thanks for your comments. Oh, okay, we did a check for endogeneity using the IV, since I mean we know all that to some extent pandemics should be exogenous, but there could be, the literature mentioned that there could be some specific characteristics that may help to predict pandemic. I don't know if this is true, if this is not true, but at least empirically we did. Okay, we did not augment our baseline using the IV and the smooth transition, so to let the transmission channel interact with the IV approach. But basically this can be done because there is a way to do empirically this. I see your point when you say that there is like an interrelation of the three things, at least pandemics that impact employment and economic activity in general, and then this has an effect on fertility. But this is our way to model this, is to use the smooth transition function that allow to discriminate, let's say, like a dummy variable approach between higher and lower levels of the transmission variable. Of course, you can put in a system like a VAR, for example, but this is equivalent. The literature show that using the local projection approach allow to have more flexibility than a traditional VAR, but of course this can be replicated using a VAR, for example.
Thank you.
Thank you. Other questions or comments? All right, so we will move to presentation by Manuel Serrano-Alarcon on long-term unemployment subsidies in health.
So thank you very much for organizing this workshop. I'm Manuel Serrano-Alarcon, and I work at the Competence Center on Microeconomic Evaluation of the Joint Research Center of the European Commission. And this is joint work with José Ignacio García-Pérez and Judith Vall-Castello. A bit of motivation of the paper. So most of the research on the welfare effects of unemployment insurance has focused on their potential moral hazard effects and on their potential detrimental effects on the labor supply. And taking these into consideration, it is thought that the optimal design of a unemployment insurance is the one that equalizes the cost as measured by moral hazard and the benefits as measured by consumption smoothing. However, there are other potential and unexplored costs and benefits that might be taken into account when doing the optimal design of unemployment insurance, such as the health effects, which are the ones that we focus in these papers. The few studies on the effects of unemployment benefits on health show mixed results. So on the one hand, those that look at the intensive margin of unemployment insurance, they show that more generous unemployment benefits might lead to better self-rated health, for instance, in the US and in Germany. There are other few studies that look at the stencil margin. In particular, the closest to us is the one that looks at the effect of the stencil margin of unemployment benefits in Austria, and they found health improvement for women with no effect for men. In this context, the objective of this paper is to examine the effects of receiving a non-contributory benefit for long-term unemployed on the health of the workers. What we do is to exploit a reform that was implemented in Spain in 2012 and that creates exogenous variation in the access to this long-term unemployment subsidy by increasing the eligibility age from 52 to 55 years old. We focus on several health outcomes, mainly hospitalizations that are related to work, such as injuries and mental health diagnosis, and other self-reported mental health outcomes. Our contribution we have different contributions. So on the literature for unemployment benefits effects on health, we study the extensive margin rather than the intensive. Most of the study look at the difference between generosity of unemployment benefits, and we focus on a group of the population that has very large great risks of suffering poor health because they are long-term, middle-aged, unemployed who have suffered a cumulative disadvantage in the labor market. They are lower educated, lower skilled, and they have poor labor market records. So that we can ask whether to what extent a social program can protect the health of previously disadvantaged group of the population. So the benefit that we are studying has the following characteristics: is a non-contributory benefit for middle-aged long-term unemployed that is thought to be a last resort benefit because you need to have depleted all the general unemployment insurance and unemployment benefits to access to this benefit, and it amounts for around 400 euros per month, which corresponds to a 30% replacement with average salary. It has a duration that can be postponed at maximum until retirement. So many people who cannot find a job use it as a bridge to retirement. What we show with descriptive statistics is that the recipients are lower educated than the average, and they have a very much interrupted labor market track. There are some differences by sexes, in particular with the sector where they work. Men are overrepresented in the construction sector and women in the manufacturing sector. And the reform that we exploit to measure whether accessing to this benefit has any health effects is that in July 2012, the minimum age to access this benefit was suddenly increased from 52 to 55 years old. So that in our identification strategies, we have two cohorts of people depending in which half of the year they were born. So those born in the first semester of 1966 were the last one that could access to the benefit when they were 52, whether those born after July 1960, they could not access until they were 55, so until 2015. And that's our control group. Additionally, we use as an additional control group the closest cohorts to clear out any differences by semester of birth, so that the only cohort that can access to this benefit in 2012 is those born in the first semester of 1960. So this will be our treatment cohort, and we compare the cohorts before and after the reform in a triple difference model. The data we have first labor market data, because we want to look at first at the labor market effects, and we use a representative random sample of 4% of the Spanish workers. We have lifetime labor market records, including all the contracts, all the characteristics of their contract, whether they receive subsidies and so on. So that we use the subsample of 60,000 individuals, and we observe them from some years before the reform, from 2009 to 2014. The main analysis on health outcomes is done with hospitalization and using hospitalizations by main diagnosis. We also focus on this sample of people born between 1960 and 1962, but we aggregate the data by province, cohort of birth, semester of birth, and year, and we construct hospitalization rates of these cohorts over time. Therefore, the analysis on hospitalization is always an intention to treat analysis, because we could not follow the same individuals over time, but rather we have hospitalization rates by cohorts. This will be the main model that we replicate similarly to labor market outcomes and hospitalizations. Here I have for labor market outcomes, so it's a simple triple difference where the three dummies that determine whether you are treated or not. It's being born in 1960, being born in the first semester, and then the interaction of art after 2012, after the reform. Therefore, our estimate of interest is the triple interaction of cohorts, first semester, and after 2012. For employment, we look at in the paper, we have 6 different labor market outcomes. Here I would focus on 4, whether they are employed, whether they are receiving the long-term unemployment subsidy, whether they are unemployed, receiving other subsidy, or out of the labor market. We plot the results into event study-like model, so leaving always as reference category the year before the reform, so that if there was any effect of the accessing the long-term unemployment benefits, that we need to find significant effects after 2012. Here on A, we see that the cohort eligible, the last cohort eligible to long-term unemployment benefits, increase the probability of accessing long-term unemployment benefits, and the increase was larger for men. So we have 4 percentage point increase for men that was stable over time, and around 3 percentage points for women. What was the alternative to receiving long-term unemployment benefits? So the main alternative was leaving the labor market. So those who could not access the long-term unemployment benefits actually leave the labor market, because there was a decrease in accessing, in the probability of leaving the labor market for those eligible. And also there was some decrease in employment at least 3 years after for men, whereas for women there is no much effect on on getting unemployment. So overall, this suggests that ineligible men are more able than ineligible women to find a job during the second and third years after the reform. We also found some substitution effects in partial disability benefits that we don't show here. And now moving into the effects on hospitalization rates by diagnosis. So we are interested in work-related hospitalization following the previous literature, mostly mental health effects and physical health effects. That here we focus on injuries. We see that there is no effects on mental health hospitalization. However, we see a drop in injuries hospitalization rates for those who could access the long-term unemployment benefits, and this is driven mainly by men. So there is a reduction for men that is around 13% compared to the average in injuries hospitalization rates, and not for women. Whereas we don't find any effects on mental health or on the other most relevant diagnosis. However, a mental hospitalization rates might be thought as a very extreme outcome. So to be to the hospital, it must be very extreme mental health problems. So we looked also, we have a sample that is representative of primary care users in some of the regions of Spain. And we know whether they have any mental health diagnosis over time. And here what I show are the results of the triple differences. So this will be the triple difference effects is the effects of accessing of being eligible to long-term unemployment benefits on the probability of having any mental health diagnosis. And similar to what we found before, it's that we don't find any effect for women, but we find a reduction in mental health diagnosis for men that were actually those who were more affected by the reform because they could access more to long-term unemployment benefits. Discussion and summary of the results. We first saw that those receiving long-term unemployment subsidy have a background of very poor socioeconomic conditions and a poor track in the labor market. And then the reform exogenously altered the employment status. Particularly eligible cohorts increased access to long-term unemployment benefits, more men than women, and not eligible individuals were mainly pushed out of the formal labor market. We don't observe the informal, whereas men also increase employment in the medium term. Regarding physical health injuries, we saw that the men eligible to long-term unemployment benefits reduced their hospitalization due to injuries by 13%, whereas there was no effect for women. We explained this by two facts. First, that men are more exposed to the reform than women. They increase more the probability of receiving the subsidy when they are eligible, and also men receiving the long-term unemployment subsidy come in a larger proportion from more physically demanding jobs, particularly construction sector where injuries are more prevalent. Regarding mental health, we don't find any effects on hospitalization, even though this could be a very extreme outcome, but then we find a reduction in the probability of diagnosis of primary care, and again, only for men and not for women. The policy implications is that the research shows that long-term unemployment benefits can improve the health of the middle-aged workers who are in a particularly disadvantaged position in the labor market. We just run very simple back-on-the-envelope calculation and calculate that by increasing the age requirement to access the reform, there was also an increase in the expenditure, hospital expenditure associated with injuries of around 2 million euros per year. So we discussed that the health externalities should also be taken into account when considered the modification of unemployment benefits schemes. That's all. Thank you very much.
Thank you very much. Let's open it up for questions or comments. Anyone? And well, I was wondering if in your cost benefit analysis, if you were able to calculate something more like the cost per averted hospitalization or cost per averted mental health diagnosis.
I don't remember by heart, but we first did, so the way we did it, because this is ITT analysis based on hospitalization rate, so we calculated something like something like 1,000, a bit more than 1,000 hospitalization per year, and then we simply assign a price to each hospitalization based on Ministry of Health Statistics hospitalization, but we don't really observe the real healthcare cost, just an average. So it's very simple back of the envelope cost calculation.
Okay. Thank you. Anyone else? Well, thank you, everyone. I think this has really been, I've done a bunch of these, and I think this has been one of my favorite panels, both because each paper has been so interesting and all of the presentations have been so carefully constructed for the audience. I appreciate everyone's participation and hope everyone has a great evening or day, depending on where you are.
Just as a last remark, Evelyn Skoy was registered. I also sent her an email during the event. She has not answered. We don't know what's happening. So I'm sorry, but this means we are off a little bit earlier and have lots of inputs and further thinking on interesting research topics. Thank you very much for joining this afternoon, at least in Europe, the afternoon in Europe. Okay, take care. I take now down
Thank you very
recording.
much.
Okay, bye-bye.